Hi everyone, I'm back again for this next part in the gastrointestinal alterations lecture. And what we're going to be doing next is the inflammatory disorders. And as you can see on here, um, I've got gastritis as the first one here, but a few things to keep in mind when we're talking about the inflammatory gastrointestinal disorders. Number one, we see that they follow a chronic clinical course, meaning that we don't have an absolute cure for a lot of these inflammatory conditions. And number two, inflammation is a key component to these disorders. And the inflammation can either exacerbate or get worse, or it gets better. And it kind of follows that cycle of flaring up and then calming down and then flaring up and calming down. And we don't really understand exactly what's going on or what's causing this inflammation, this chronic inflammation in the GI tract. We think that genetics have a role to play in this. Also, we think that the immune system is either hypersensitive or is reacting to normal gut flora and causing this inflammatory response. Bottom line is, we don't fully understand what the etiologic triggers are for the inflammatory gastrointestinal disorders. And if you notice this first one on here, I have gastritis. And you can see down here in these large letters that gastritis is not an inflammatory bowel disease. Gastritis, yes, it is inflammation in the stomach specifically, but we do not characterize gastritis as an inflammatory bowel disease. It is an inflammatory process, but it's not one of the inflammatory bowel diseases. And we'll get to those, the inflammatory bowel diseases, coming up in a few minutes. So let's transition to full screen here and get going. Gastritis. So remember, anytime you see itis at the end of anything, that means inflammation of whatever the root word is. So this is inflammation of the stomach, and it's the gastric mucosa that's inflamed here. We can have acute gastritis and chronic gastritis. And acute gastritis is usually caused by ingestion of irritating substances. So that could be overindulgence of alcohol or aspirin, that's what ASA is, or NSAIDs. Or it could be a sudden onset viral or bacterial infection or a sudden autoimmune attack to the gastric mucosa. Either way, it's acute. So it's a quick onset and is usually resolved by removing these irritating and offending substances. Chronic gastritis, on the other hand, is almost always caused by persistent H. pylori infection. So we've got another endoscopic view here of gastric mucosa. We're looking inside somebody's stomach, and we can see these red striations of the gastric mucosa. That's evidence to us that there's inflammation going on, causing this erythematous appearance of the gastric mucosa. So this is evidence of gastritis. I don't know if this is a chronic or an acute gastritis case, but it's inflammation of the gastric mucosa nonetheless. Okay, so now let's talk about the inflammatory bowel diseases. And there's two major inflammatory bowel diseases, or you'll see it abbreviated IBD. And again, these are chronic relapsing inflammatory disorders characterized by remissions and exacerbations. So it's better or not as bad for a while, and then it flares up and gets worse. And then here are the factors that I listed earlier on in the video lecture: the genetic component, immune system component. We're not sure exactly what's going on here. And then the Evolve video, you guys have access to this through the Evolve website page for our textbook. They kind of have a pretty good overview of the inflammatory bowel diseases. So the first one that we're going to look at is ulcerative colitis. So this is definitely an IBD, an inflammatory bowel disease. And what's going on with ulcerative colitis? It's chronic inflammation that will lead to ulcerations forming in the colon mucosa. So sigmoid colon and rectum, those are the most commonly involved areas for ulcerative colitis. And what we see here is edema and thickening of the colonic wall that actually will start to narrow the lumen of the colon. And as it ulcerates and becomes thick and swollen and edematous, these are all inflammatory characteristics, that creates a situation where we're losing surface area for absorption. And if you remember, we're absorbing water and electrolytes from the colon. And so what results from this is large volume diarrhea, because we're not reabsorbing that water from the fecal material that's in the large intestine at this point. And ulcerative colitis does, in fact, increase the risk of somebody developing colon cancer later on in their lives because of this chronic inflammation causing cellular stress and cellular damage, plus the ulcerations and so on. So this is a colonoscopy view now. We're looking inside somebody's colon, and we're looking at the colonic mucosa here. And where we would normally see pink mucosa with some ridging, we see this mucosa that has been eroded away. So this is ulcerative colitis for sure. And we can see these island areas of normal mucosa, but these are inflamed areas of mucosa as well. So they're hyperemic, they're redder than normal, and edematous and swollen and so on. So with ulcerative colitis, the symptoms that we see here, diarrhea for sure, up to 10 to 20 times a day. And not just diarrhea, but during flare-ups, bloody diarrhea as well. And because of the colonic mucosal inflammation and ulceration, there's a lot of pain that's involved here too, and it can be described as cramping pain. So the hallmark features that I've got written down here for ulcerative colitis: bloody diarrhea and lower abdominal pain for sure. Here's a surgically resected portion of colon that's affected by ulcerative colitis. They've opened it up for us. So we're looking at the colonic mucosa here, and look how red and angry this mucosa is. There's definitely inflammation going on here, and we've got these areas of ulcerations and pitting going on as well. Looks quite painful, and you can see because of all of the inflammation and the ulcerations here that there is blood that's on the mucosa here. So definitely that follows along with our characteristic of bloody diarrhea. The next inflammatory bowel disease is Crohn's disease. And again, it's inflammatory, so there's the inflammatory process gets initiated here. And what makes Crohn's different from ulcerative colitis is that it can affect anywhere along the entire gastrointestinal tract. So we use the term from mouth to anus. That's from beginning to end of the GI tract. We can see Crohn's disease evidence showing up anywhere along this pathway. Again, it's idiopathic, meaning that we don't know what's causing this inflammatory disorder. Sometimes it's hard for us to determine if it's ulcerative colitis or Crohn's disease that we're looking at, especially if the Crohn's disease is affecting the colon. So similar risk factors and similar theories of causation as far as all of the inflammatory bowel diseases and disorders. Inflammation here is of the submucosa. So with ulcerative colitis, the inflammation originated in the mucosal layer, but with Crohn's disease, the inflammation is starting in the submucosa, and then that inflammation will spread both towards the mucosa and involve the mucosa, but also it will spread and start involving the muscularis layer and the serosal layer of the GI tract where this is happening. And so we see that with a Crohn's disease flare-up, if we were to take a biopsy of flared-up tissue, we would see that there would be a lot of activated neutrophils and macrophages in the area, so there's definitely an immune system component to this. And what all of this inflammation will cause visually and macroscopically are what we term skip lesions and cobblestoning effect. And I've got a good picture of that coming up in the next slide or two. But same thing with the chronic inflammation, especially involving all layers of the intestinal wall here, that's going to create a situation for malabsorption. So the small intestine, for instance, if it's affected by Crohn's disease, is going to become swollen and inflamed, and that will greatly limit its ability to absorb nutrients from the food that's passing by. Okay, yeah, here's some good pictures. Cobblestoning effect. It looks like a cobblestone driveway or a cobblestone sidewalk. And these bumps and lumps of the intestinal wall is caused by that submucosal inflammation. And then here we see pretty evidently we've got cobblestoning going on here as well, and the inflammation is extended all the way to the mucosa of the small intestine of this portion here. And so that would be the cobblestoning effect. And then over here, we've got an example of skip lesions where we have these areas of inflammation that looks like we can skip or jump from one to the other. And we've got some inflammatory exudate building up here as well. So clinical manifestations for Crohn's disease is up here in the box: intermittent bouts of fever, diarrhea for sure. Not always bloody though, but if we do have bloody diarrhea with Crohn's disease, it's not near as bloody as we would see with ulcerative colitis. Another feature for Crohn's disease is that there's a constant pain, and most of the time it's in the right lower quadrant region. And right lower quadrant, upon palpation, might feel a mass and definitely tenderness. So just because I've got on here that there's a right lower quadrant mass, that doesn't mean that there's a tumor or cancer right there. But think about what's in the right lower quadrant of the abdomen. Usually people will say the appendix, and that's correct. The appendix is there, but the appendix isn't really what's happening here with Crohn's disease. What is pretty close by to the appendix, though, is the ileocecal valve, that sphincter muscle that separates the ileum from the cecum or from the large intestine. And it's in this region, the right lower quadrant, right around the ileocecal valve. That's where the most common site of Crohn's disease to develop will show up at first. And so by palpating that, we're feeling an inflamed ileocecal sphincter muscle. All right, other inflammatory disorders, diverticulosis, diverticulitis. So these are diverticular diseases of the colon. We see these developing in the large intestine primarily. So what is a diverticulum or a diverticula? These are herniations of mucosa that have protruded through the muscularis layer of the colon wall. So these are little pouches that are extending beyond the muscularis layer of the colon. We see it mostly occurring in the sigmoid colon. So diverticulosis is just clinical evidence of diverticulum, so asymptomatic. There's no pain, there's no changes in bowel habits or anything, but we see diverticulum on imaging or colonoscopy. We would term that diverticulosis. Diverticulitis, on the other hand, is diverticulosis in the inflammatory stage. So when these pouches become inflamed, then we've got pain that's involved with that, and changes in bowel habits, maybe even diarrhea and cramping. We would consider that at that point diverticulitis, because we do see evidence of inflammation at that point. So here's what they look like. These are the diverticulum right here. So these outpouches of colon mucosa, basically. So the lumen can extend into these pockets that are protruding from the muscularis layer of the colon. So here's a good view: diverticulosis colonoscopy. So each one of these caverns ends in a pocket like this. But we don't see any inflammatory exudate. The mucosa here looks nice and pink. It's not red. It's not inflamed. So this would be considered diverticulosis. Diverticulitis, on the other hand, we do see inflammatory exudate, and I wish this was a better view, but I would anticipate also seeing some redness and swelling of the colon mucosa as well. All right, so here's another picture that's showing diverticulitis, because we've got inflammation that is now extending along the adjacent structures of the colon here. So this outpouching of large intestine lumen basically is a nice area for things to get stuck. So we can have fecal matter that gets stuck in these pouches and these diverticulum. We can have seeds like sesame seeds or pieces of sunflower seeds or things that just don't get digested very well. Those can find their way into these diverticulum and then they get stuck. And if fecal matter or food particulates get stuck in these diverticulum, they're going to fester, bacteria is going to grow on them, and that's going to trigger the inflammation response. And so with the inflammatory evidence here, then we would say that we're looking at diverticulitis in this case. And that inflammation can cause swelling and edema, and that can narrow the lumen of the large intestine here as well. All right, so let me go back to 2 slides here. I'd like to ask in class, what are some risk factors that you can think of that lead to the formation of diverticulum in this case? And also, I like to ask, what patient population do we see diverticulosis and diverticulitis most often in? And if you're thinking that it's going to be our older population or our aging population, you would be right. And also another risk factor for the formation of diverticulum would be constipation. If we have fecal matter that's just sitting in the colon and is not moving or passing very easily, then that can cause stress on the colon wall, and that can lead to the formation of these pouches, these diverticulum. So we mostly see diverticulitis occurring in our elderly population, and that's one of the reasons why we want to make sure that they are getting enough fiber in their diets so that they can pass stool easily, and also limit the chance of food particulates or seeds or something like that getting stuck in these diverticulum pouches, causing diverticulitis. Okay, so next, we already did that. Now let's look at appendicitis. I'm going to go full screen again. So appendicitis, just inflammation of the appendix. And as we saw in class earlier, the appendix is hanging off of the cecum of the large intestine. And one thing that people may or may not realize is that the appendix doesn't really have a full lumen to it, but it has what we call a pseudo-lumen. So there's kind of a divot and maybe a little bit of a lumen at the beginning of the appendix. So things can get stuck in there and can cause obstruction, and that can lead to inflammation of the appendix. Ischemia can cause it as well. Infection. The appendix is commonly infected, and then it gets inflamed and painful. And also ulceration, sorry. So looking at where the appendix is in the abdominal cavity, it's in the right lower quadrant for sure, and we can isolate where it's at by looking at McBurney's point, or finding McBurney's point. So from the ASIS, the anterior superior iliac spine, to the umbilicus, if you were to draw a line between there, then the appendix is about a third of the way past the ASIS. And that's what we call McBurney's point. So in testing that point, we will palpate it, but also push into it with our fingertips and then release our hands quickly. So pushing down into the abdomen compresses the appendix, but then releasing it quickly will let us know if there's rebound tenderness or not. So if the appendix is inflamed, let's just say my red pen here is the appendix. If it's inflamed, and if we press on it and then let go quickly, it's going to wiggle. It's going to jiggle like that. And an inflamed organ, if it wiggles and moves, is going to cause a lot of pain for that individual. And so that's what we're testing here. We're testing for rebound tenderness. And if that's evident, then imaging can confirm appendicitis, and then we can go ahead and send that person in for surgery, for an appendectomy, get that appendix removed before complications happen. And the biggest complication that can occur with appendicitis is it rupturing. And then we've got a rupture and a spillage of all of that infected, inflamed tissue into the peritoneal cavity, and that's what will lead to peritonitis that I've got on here. All right, next up, irritable bowel syndrome, IBS. don't get IBS confused with IBD, because with irritable bowel syndrome, current knowledge is that there's no inflammatory trigger here for IBS. I suspect that that's going to change over time. In fact, there's talk and research about microscopic inflammation that can contribute to IBS. But the bottom line is, as far as IBS goes, for a long time it was a diagnosis of exclusion, meaning that we couldn't really rule in anything else. We ruled out all the bad things like Crohn's disease or ulcerative colitis. And so then what we're left with is what we call irritable bowel syndrome. So it's still an idiopathic disorder. We don't really know of or see any structural abnormalities or biochemical alterations that are causing this problem, but it does affect a large portion of the world's population, 20%, that's 1/5. So chances are you know somebody who is affected by IBS to some degree or another. Most commonly in women and youth and middle age is the demographic here. And also IBS is closely associated with anxiety and depression. And I would be willing to argue that we don't know which is causing which in many of these cases. So is the IBS and the problems that occur with that causing the anxiety and depression, or does somebody have underlying anxiety and depression and that is translating to IBS-like symptoms? So what's going on with irritable bowel syndrome is one of two things. We've got two classifications here. There's either going to be IBS-D, which would be irritable bowel syndrome diarrhea dominant, or IBS-C, which is constipation dominant, and then there's mixed as well. So historically, IBS has been characterized by alternating diarrhea and constipation, but now we're seeing these more dominant features of diarrhea or constipation. And what's going on here, I moved this picture here because this is where it belongs. We see spasming of the colon. So the smooth muscles along the colon are spasming out of sync with normal peristalsis. And so if there's spasming or even cramping of these smooth muscles, then that's going to create a lot of pressure in the non-spasming portions and can be quite painful. And also, if this is diarrhea dominant, these spasms can cause a hypermotility and create a motility type diarrhea. Or if this is constipation dominant, then the spasming can limit how much fecal matter can move and create constipation. So anybody who has IBS will tell you that it is definitely uncomfortable and can cause lifestyle alterations for sure. And it's very common, so you'll likely come across that clinically. So shifting gears a little bit, let's look at obesity because this does involve the GI tract to a certain extent. Obesity, by definition here, body mass index or a BMI greater than 30. We do know that there are hormones involved with the development of obesity and also maybe hypothalamus dysfunction. The hypothalamus is the main regulator of hormones up in the central nervous system. And so finding out the causes of obesity will show us that there are several causes. There's any number of causes that can lead to obesity and weight gain. So, but what we do know for sure is that it's a risk factor for so many chronic diseases, and even increases the risk of death and morbidity with other disease processes as well. So I don't want to get into a whole lot about obesity here. We do see hormonal regulation of appetite and calorie consumption, and sometimes these hormones, leptin in particular, can start giving the wrong signals, or they're not responding to the appropriate signals to stimulate hunger with the hypothalamus, and that's what can lead to obesity. So in this case, leptin, the hormone, is increased, and that will cause an increase in hypothalamic action and lead to overconsumption of foods and also inappropriate calorie storage by way of storing those calories in the form of fat. So you might also be familiar with the different body shapes, apple shape versus pear shape. So apple shape is more of an abdominal obesity. And we see this occurring with folks that are consuming too many calories for what their body requires. And so those extra calories get put away in the abdominal fat. Pear shape weight gain, though, around the hips and upper legs, this type of fat distribution is more commonly associated with hormonal alterations. So, like in gals, this could be evidence of estrogen dominance, where there's not enough progesterone to balance out the effects of estrogen, or maybe there's just too much estrogen, something like that. So that's really all I wanted to highlight on this picture, is that there's so many different types and causes of weight gain and obesity, and sometimes looking at where the weight gain is happening can give us clinical clues as to what's causing it. So then let's talk about eating disorders. The characteristics of eating disorders are listed right here. So abnormal eating behavior, abnormal weight regulation, and disturbed attitudes towards someone's own body weight, shape, and size. And so anorexia nervosa is the first specific type of eating disorder that we've got in the lecture today. So if you remember, anorexia, just anorexia by itself means someone's not hungry, or they're not eating, they have no appetite, they don't want to consume any food. But anorexia nervosa is somebody that's refusing to eat on purpose, even though they may actually be hungry. And what triggers this could be up for debate, but what we see commonly in individuals who suffer from anorexia nervosa is that it starts with poor body image, or feeling inadequate, not living up to cultural norms and things like that. So the big risk with anorexia nervosa not only would be nutrient depletion and calorie restriction, but loss of normal fat and loss of muscle. Because if the body is burning more calories or needing more glucose than what that person is consuming, the body's going to grab fuel from anywhere. And so normally that will start with stored fat. But once they've burnt through all of their normal stored fat, then the body will start getting fat from physiologic areas of fat, or anatomical areas. So the fat behind your eyes, the retroorbital fat, or the fat that surrounds our organs like our kidneys, that's supposed to be there to cushion the kidneys and keep them safe. The fat on the bottom of the feet. So that structural type of fat starts to get lost, and also muscle depletion as well, because the body's going to break down proteins for energy production as well. And so all of this over time can lead to cardiac failure in our anorexia nervosa patients, because they're basically starving to death. It's a very slow starvation process that can end their lives with cardiac failure. Bulimia, on the other hand, is where somebody who suffers from bulimia nervosa will typically have a normal body weight. But I crossed out aspirations here because there's a lot of people who aspire to lose weight, especially when they need to. But what's going on with bulimia nervosa is that they have a very kind of obsessive, strong desire with weight loss. They're just not restricting calories. So what bulimic will do is they will binge eat and then throw it all back up. So self-induced vomiting. And then sometimes they'll fast after they binge eat or eat a large meal. They'll fast to try and oppose the effect of eating all of that food, or they'll go out and exercise excessively. So it's an obsession here with bulimia, and the characteristics is that they'll binge eat and then purge, and that's basically self-induced vomiting. So vomiting over and over and over will cause symptoms like what we see with GERD, except worse, because all of that acidic chyme is coming up the esophagus and into the oral cavity, and that can cause damage to teeth It can cause esophageal and pharyngeal inflammation, even the formation of tracheoesophageal fistulas, which is a communication. It's a canal that will allow communication between the esophagus and the trachea. And also, if somebody doesn't use the vomiting method, they'll overuse laxatives, and that can cause damage to rectal mucosa as well. All right, so looking at malnutrition and starvation now, these next couple slides involve cases where it's not the person's choice to be malnourished or starvation. So starvation, by definition, is just listed up here. It's a decreased caloric intake. That will definitely lead to weight loss. And cachexia is the result of prolonged starvation. Cachexia is basically wasting away. So somebody's losing their fat mass, they're losing their muscle mass, and start looking like basically a skeletal person. We've got two different types of starvation: short-term starvation and long-term starvation. Short-term starvation happens every time you go to bed at night and you're sleeping and you're not eating for several hours. So the body will use processes like glycogenolysis, breaking down glycogen that's stored in the liver to release glucose into the blood, and then cells like neurons can use that glucose to keep their functionality going and keep us alive. Long-term starvation leads to significant metabolic changes and characteristic presentations. So marasmus and kwashiorkor, these are two conditions that I've got pictures of coming up next. One thing that I forgot to mention about cachexia, though, is that we see cachexia developing in many of our chronically ill patients and even terminally ill patients. So think of a terminally ill cancer patient. As the body is shutting down and wasting away, we would definitely see cachexia in that example. So marasmus and kwashiorkor. Marasmus is this example right here. This poor little guy right here is nutrient depleted across the board. So we have this presentation because of protein depletion, sugar depletion, not enough carbohydrates, not enough proteins, not enough vitamins. This is just straight up starvation. And notice the person has to hold this baby's head up. They're just so weak, they can't keep their eyes open, basically starving to death. Extremely sad to watch. And then kwashiorkor is this, are these examples right here. So notice a couple differences here. These little kids are standing up on their own, and they're older than this guy over here with marasmus, but we see these protuberant abdomens with really thin bodies. And what's going on with kwashiorkor is protein and lipid starvation. So they're getting enough carbohydrates somewhat, but definitely not enough proteins and lipids, and that's what's causing this protuberant abdomen appearance. So a couple reasons why. We see this in areas of the world where starvation is a big concern, where there's not enough nutrition for babies in particular. And so if a mother has a baby and cannot supply breast milk or any sort of food for that baby, we would see marasmus. If that mom is able to breastfeed for a little while, then the baby thrives to live to these kids' age. But then perhaps that mom has another baby, and so then the newborn is now consuming all of the breast milk, and then these kids are left without those proteins and lipids, and develop malnutrition and starvation at a later age in their childhood, like this. So I know you guys don't have this picture in your bound notes book, but I just took this off of the World Health Organization website. These are areas of the world where malnutrition and starvation is still a serious problem. So more than 15% acute malnutrition. That's these red areas here. So India and sub-Saharan Africa, those areas of the world still struggle with being able to provide enough food for their little guys and for their babies. Okay, I'm going to take a break again right here, and when I come back, we will finish up the gastrointestinal disorders. We'll start with liver disorders and look for that coming up soon.